All right, for this final lecture for our week on cardiovascular system, I'm just going to kind of tie everything in that we've talked about up until this point. So we're going to talk about the anatomy of the heart and how blood moves through the heart. We've gone into the electrical stuff, and now I want to talk about what's actually occurring in those chambers mechanically, what all the valves are doing, things like that during the cardiac cycle. So we're going to kind of tie in the last bit here with the mechanical aspects of the heart. So the cardiac cycle is basically one heartbeat. So one cardiac cycle is one heartbeat. That's the period of the atria filling and contracting, the ventricles filling and contracting. And when we talk about these terms systole and diastole, systole would be the contraction of the heart chambers. So we have atrial systole and we have ventricular systole. So atrial systole would be the contraction of the atria together. Diastole would be the relaxation of the heart chambers. So if they're not contracting, they're relaxing, right? Or filling. So during atrial systole, the ventricles are in diastole. So as those atria are contracting and pushing blood in to the ventricles, those ventricles are in a relaxed state. They have not contracted yet. So as the atria are in systole, the ventricles in diastole, and vice versa. And so the atria are contracting in unison, the ventricles are contracting in unison, and then all chambers just kind of pause. On that EKG, it was that point after the T wave before the next cardiac cycle. And this shows that regular pattern of impulses on an EKG. We call that sinus rhythm if it's normal. And then if it's abnormal, then we have arrhythmias. We already talked about those as well. And this is all based upon the volume of blood in the chambers and how much pressure that volume is excreting in those chambers. So recall that we have valves. Okay, so we've got a tricuspid valve and we have a bicuspid valve. Now, as this atria is filling, it's filling from the inferior vena cava, superior vena cava, and coronary sinus. So SVC, IVC, coronary sinus, all of that is dumping deoxygenated blood into the right atrium. Now, as volume increases, pressure increases. So if you remember nothing else, I do want you to remember that concept. As volume of blood increases in a specific area, the pressure is also going to increase. So as this atria fills with blood, its pressure is going very high. And this ventricle is technically empty at that point. This valve is closed. As that atria fills, its pressure is going to be much greater than what's on the other side of this valve, which is the ventricular pressure, which is essentially, it's something, but it's essentially nothing for simplicity terms, right? That pressure, that volume, that pressure buildup here in the atria is going to force that AV valve open. Okay, so and that pressure is increasing as that SA node is firing. So the SA node, remember, simultaneously as this valve opens, right, we've had depolarization here of all of these cells. So the electrical activity basically went through that depolarization where those cells are able to do something or conduct an action potential to contract. So as that depolarization is happening, these atria are becoming to the point where they are getting so full that they need to contract and push that blood through. And the opening of the valve is controlled by that pressure change on either side. The contraction is driven by the electrical impulse, but the valve is opened mechanically by the pressure in this cavity becoming so great. So these things are happening at the same time. You kind of have to think about it in two different ways and then integrate it together. So that atria then, when they're full and they have that great pressure, now they're going to go through a period of systole or contraction, and they're going to force those valves open, both valves, right? Because the atria are both contracting together, they're both filling. The left atria is filling from those pulmonary veins from the lungs. That's going to force the tricuspid and bicuspid valves open and then fill up the ventricles. As those ventricles are filling, they're in diastole. So if they're filling, they're in diastole. So those atria were in diastole, then they're going to contract and they'll be in systole. Ventricles are going to fill, they're in diastole. As that's occurring, right, this impulse from the SA node is about here at the AV node AV bundle. Then depolarization of all of these cells of the ventricle is going to happen. And then when those ventricles are full, they're going to contract. So they're going to contract based upon the electrical impulse here, this depolarization, but they're also going to contract, or they're going to force blood through the pulmonary valve and aortic valve based upon pressure is going to open those valves. So once we have this pressure in this ventricle exceeding the pressure in the pulmonary trunk, this pressure in the left ventricles exceeding the pressure in the aorta, because ultimately we're assuming that those two major vessels are empty, right? If they don't have volume, they don't have pressure. So that pressure in the ventricles is exceeding that. That's going to force those valves open. It's kind of like a swinging door, like in a restaurant. That's going to swing those doors open and allow that volume to move through. Something else to note on this is that as those ventricles are filling, they are forcing these AV valves shut. And so that's important because when these ventricles contract, we don't want these valves opening, right? We want the valves opening to the pulmonary trunk and aorta. So not only does that pressure force closed the AV valves, but it's also going to open up our semilunar valves. Okay, so as those ventricles were filling, 70% of the volume is actually entering the ventricles prior to atrial contraction, which is kind of interesting. And then the atria will contract and they will force the remaining 30% of blood into those ventricles. At 70%, our pressure has already exceeded that of the ventricle, and so those valves will open. And so at 70% full, they will start to fill the ventricles, and then they'll squeeze to eject that last little bit of blood into the ventricle. So if we're contracting, we're in systole. If we're relaxing, we're in diastole. That's something to remember. And if you want to kind of put the polarization terms in with that, you have to be a little bit careful, but essentially for simplicity, you could say that during contraction, that happens right after depolarization, and relaxation will be happening during repolarization. So as the ventricles contract, the atria are in diastole, right? They're filling. So as these ventricles are contracting, these atria are already filling for the next cycle. They are getting blood from the SVC and the IVC. And then the AV valves are closed, right? I already kind of talked about that because we don't want backflow. And they're getting ready for that next cardiac cycle. You have some videos that I've assigned you to watch that will make this a little bit more, make a little bit more sense for you. So here is atrial systole. So atria, we're assuming they're full here from the IVC, SVC, and pulmonary veins. And that pressure, as that volume increases, that pressure is going to increase and force these AV valves open. That is also simultaneously the pulmonary valve is closed and the aortic valves are closed. Those ventricles are going to fill because they're in diastole. And then when the ventricles are ready to contract, now they're in systole, and the atria are going to be in diastole. And this is just showing those atria in diastole as the ventricles are squeezing, getting blood from the IVC, SVC, and pulmonary veins. Then the ventricles are going to contract, and notice how the AV valves are closed, tricuspid, bicuspid, but that's going to force open the aortic valve and the pulmonary valves so that blood can go to the lungs and to the body. So contraction, systole, relaxation or filling is diastole. So that's kind of the mechanical idea. And then you also do need to just be aware of what valves are open and what valves are closed. And if you can just remember the directional flow of blood through the heart, I think you should be able to get that pretty easily. Now, this cardiac cycle, remember that the SA node self-fires. but it can be controlled by the nervous system if needed. And it's all regulated by stimuli, receptors that are detecting how much blood is being pumped out to the body and whether or not the cells of the body have enough oxygen, nutrients, waste, release, things like that, according to how fast the SA node is firing. Now, if you're exercising, for example, if you're exercising, you're using your muscles. And as your muscles are contracting more often, they're using more oxygen. So if that were to happen, we would need to increase your heart rate to pump blood faster out into the body to deliver oxygen to the tissues more often. Okay, so that can be controlled by the nervous system if need be during certain events of the body. Different homeostatic deviations, I should say. That is all controlled by the cardiac center in the brainstem called the medulla oblongata. That's the bottom part of the brainstem right here. So there's some neurons in there that are directing this. That's the control center. So we have receptors all over the body that are detecting our cellular requirements and seeing if what our heart is doing is sufficient to meet those requirements, and then telling the control center to either tell the heart to beat faster or slower, or if it's all okay, right? And the sensory info comes from a lot of different things. Pressure for one, so blood pressure and heart rate are related. If your blood pressure is increased, your heart rate is also increased. And if you think about that, we're going to get into this a little bit later, but if your pressure is high, that means that it's really hard for that blood to get, like there's a high volume of blood going through those arteries, or it's maybe hard to pump it. So your heart is going to accommodate for that by trying to beat faster to try and push it through faster. Also chemical receptors like detecting oxygen level, carbon dioxide level, maybe even pH. Movement, which would be your proprioceptors. Proprioceptors detect movement in terms of like exercise, something like that. And those motor impulses are going to travel to the heart or the SA node. That's going to be the effector. Remember, we have a receptor, control center, effector. Our effector is going to tell the SA node to either fire faster or fire slower. So just to reiterate, the SA node is self-firing, but in terms of homeostasis, it can be directed by the nervous system if it needs to be. So this is just what this looks like. So remember, we have receptors all over the body that are detecting a change in cellular requirements. A sensory neuron is carrying that message to our control center, which is going to be our medulla oblongata. And then the motor impulse is telling the SA node to fire faster or fire slower. There are two different types of autonomic nervous system. There are two divisions of the autonomic nervous system. There is the sympathetic nervous system and the parasympathetic nervous system. If you have not had 215 yet, the sympathetic nervous system is always going to be the nervous system that increases something, increases your heart rate, increases the rate of breathing. Parasympathetic is going to be what slows it down. And so both of those nervous systems are working in conjunction in order to speed up that SA node firing or slow it down, depending on what's going on in our body. So this is just showing our receptors. These are pressure receptors or baroreceptors, for example. You have pressure receptors that are detecting our blood pressure in the carotids as well as the aorta. And they are telling the medulla oblongata what's going on. And if we need to make a change to our heart rate. And so then the effect here, we have our integration in the brain, and then our effect would be targeting the SA node. You can even target the AV node as well. Or you can even target like the bundle branches, Purkinje fibers, all of that type of thing. So I'm going to get into this in a little bit more detail here. Yes, so parasympathetic division of the autonomic nervous system is our rest and digest. So that's going to slow down our heart rate if we're talking about cardiac function. And how it does that is it secretes a neurotransmitter called acetylcholine into the synapse between the cells that are depolarizing. And that's going to slow down our SA and AV node firing. And it's going to make it happen at a slower speed. And so that will slow down our heart rate if our heart rate is too fast. The sympathetic nervous system would be the opposite. So that's our fight or flight. That's like our stress response, right? And we all know that when you're stressed or scared or something like that, your heart rate goes up, your breathing rate goes up, all of that stuff increases. And so that would increase the SA node firing by secreting norepinephrine, which is a hormone. It can also be like a neurotransmitter, increasing the SA node firing, making it fire faster. To increase our heart rate, just depending on what's going on in our body. This would be like if you're exercising, right? So if you're exercising and your muscles need more oxygen, then you're going to have norepinephrine released by the adrenal medulla, and that's going to stimulate the SA and AV node to fire more often. And then again, you have those stretch receptors that are detecting pressure changes in the aorta and the carotids. You also have them in the vena cava, the superior and inferior. And there's a couple of reflexes here, which a reflex, if you have not had 215, a reflex is just a very quick nervous system response. It's faster than a usual, like a typical nervous response. Usually the integration just happens in the spinal cord. The message doesn't even need to go to the brain. And so that's kind of what a reflex is. That's a very quick response to something. So for example, let's just say that your carotid baroreceptors and your aortic baroreceptors are sensing that there's a really high blood pressure going on. And in order to detect that, if there's a high blood pressure in these vessels, those vessels are going to be stretched. And so those baroreceptors are sensing that stretching in those areas. What it's going to do is go and tell it's going to send a message to the spinal cord and say, hey, the pressure is way too high right now. And that's going to send a message to the SA node to tell it to decrease its rate of contraction. So here's what that looks like right here. So here's your receptors here. That's going to send a message, and look, we're just going to the spinal cord here. Integration is happening, and then we are going out to the SA node and the AV node, telling them to fire less often. Cardioaccelerator reflex would be the opposite. If your blood pressure is too low, that means that we need to pump that blood faster with more force. And so that would speed up the SA node, AV node firing. And we know that our emotions and mental state has an effect on how our cardiac cycle is operating. For example, fainting is due to a decrease or results in a decrease in our heart rate, and anxiety would be an increase in our heart rate. Body temperature increases heart rate. That's why when you have a fever, you might have an increased heart rate. Ion concentrations also, remember that plasma membrane with the sodium and calcium on the outside, potassium on the inside. If one of those ion concentrations is originally too high, due to maybe dietary changes or kidney problem or something like that, that can affect how well your heart muscle is contracting or depolarizing. Hyperkalemia would be too much potassium. Hypokalemia would be too little potassium. Hypercalcemia would be too much calcium, and hypocalcemia would be too little calcium. And there's just some arrhythmias that can kind of come out of those ion imbalances. Okay, that is cardiac heart related stuff. I'm going to talk a little bit about blood pressure because you have a lab on this week. When you're measuring blood pressure, you are measuring arterial pressure. So arterial pressure can be a really good indication of how well our body is adjusting to a high or a low pressure based on heart rate and other things like that. And it's due to ventricular systole or ventricular contraction. So it can be a really good indicator of how well our ventricles are working. And the systolic pressures is the top number of your blood pressure. The diastolic pressure is the bottom number of your pressure. Systolic pressure is the maximum pressure that's occurring during ventricular contraction. And then diastolic pressure would be the least amount of pressure just prior to the next ventricular contraction. So sometimes people say the systolic pressure is how well your ventricles are contracting, and diastolic is how well your ventricles are relaxing. Sometimes people kind of say it that way. It's measured using this apparatus here, and I can never say this word correctly, but it's sphygmomanometer, okay, and a stethoscope. So they put the cuff around the upper arm, the brachial region right here. The artery that we're measuring there that you should know from last week is the brachial artery. So we're measuring the pressure in the brachial artery there. And then the stethoscope goes on the antecubital region, which is just the inside of your elbow right in here, to listen for beats, pulses. All right, so how do you measure blood pressure? This is what you're going to do in your lab this week. So you're going to place the cuff around the brachial region and place the stethoscope over the inside of the elbow. Pump air into the cuff until that cuff pressure exceeds the pressure in your brachial artery. So usually it's about, usually they'll pump it up. If you're like a normal individual, they'll pump it up to like 140, 160. Sometimes people go up to like 200. And this is measured in millimeters of mercury. And then they'll slowly let the air out of the cuff to restore blood flow. So essentially what you're doing to pump up that cuff is pinching off the brachial artery and taking that blood flow away momentarily. Once you start to release the pressure in that cuff, then that brachial artery starts to open again and restore that blood flow. And what people are listening for through the stethoscope, which is what you'll experience this week, is a beat. And so as you release that pressure in the cuff and blood spurts through that brachial artery again, because blood flow is beginning to get restored, you'll hear a tapping sound, like a beat. That's called a Korotkoff sound. That's your systolic number. So you watch the little ticker on the gauge, and that number is what you would record as the top number of your blood pressure. That tapping is going to occur as pressure is let out of the cuff, and then eventually that tapping is going to disappear because now blood flow is fully restored. And that's going to be your diastolic number, is when that tapping sound goes away. And that's the bottom number of your blood pressure. So what does that all mean, right? What is blood pressure? It's determined by cardiac output. Cardiac output is a measure of how much blood is being pumped out of your heart per beat, multiplied by beats per minute. So let me just write that down for you. Okay, so cardiac output is something that we call stroke volume, which stroke volume is volume of blood pumped per heartbeat, per ventricular contraction, multiplied by your beats per minute. This is how many times the heart beats per minute, which I'm just going to say normal is like 60 to 80. Okay, so that means that cardiac output's units is volume per minute. So cardiac output is how much, sorry, the sun is not being friendly right now. So cardiac output is how much volume your blood is pumping per minute. Okay. Stroke volume is the volume of blood per beat. We multiply that by how many beats per minute, and then we get volume per minute. So cardiac output is the volume of blood being pumped per minute. So that's something that's that blood pressure depends upon. Another thing that blood pressure depends upon is how much volume that actually is, right? And then peripheral resistance, which is how easily is blood flowing through those arteries. Ideally, those arteries have that nice smooth surface, which blood cannot stick to, and it's flowing very easily. There's little to no peripheral resistance, but that's not always the case. Hypertension is high blood pressure. That when that happens, the higher pressure that's in the arteries, the less the arteries can recoil between beats. So as your heart beats, we have this expansion of your arteries like this. That's when you feel pulse. That's what you're feeling. You're feeling this mechanism. Okay. And once that blood flows through that artery, we're like this. When that blood is not in the artery, now we're recoiling, right? And that recoil doesn't happen as easily in hypertension because you're sustained at this for such prolonged periods of time because that pressure is so great that wall is going to weaken and it's not going to be able to snap back as easily. It's kind of like a rubber band, right? The more you stretch out that rubber band, the weaker it gets and the less elasticity it has. Problem with this, you are at risk for a lot of different things if you have hypertension. Aneurysms. If we're talking about the anatomy of a blood vessel, an aneurysm is like a bulging in the arterial wall. And so if we have that bulging in the arterial wall, that's due to loss of elasticity. That wall becomes thinner and weaker, and you are at risk for that wall tearing. And then atherosclerosis is another problem. And arteriosclerosis can also go in this, which is basically atherosclerosis would be the buildup of plaque in the artery wall. Arteriosclerosis is the hardening of those arteries. So if your arteries are very hard or they have plaque in their wall, they cannot recoil as easily. So hypertension can weaken the arterial walls to the point where they don't recoil as easily, and that can be really problematic. Hypotension is going to be low blood pressure, and that's typically just due to low blood volume. A lot of times it's dehydration, right? How much water does your blood plasma have at any given time? Or if you're traumatically bleeding, losing blood very quickly, anemia, loss of red blood cells, things like that can all cause hypotension. So let's talk a little bit more about peripheral resistance. So remember that the arterial walls are normally very smooth, so that blood doesn't normally want to stick to those walls. So you usually don't have blood clots in a normal, healthy individual. Basically, peripheral resistance is the idea of friction in those arteries. So as blood is pumping through that artery, there is naturally some friction in that artery that's slowing that blood flow down to a certain degree. That's peripheral resistance. Now, how much friction is happening depends upon three things. How big the lumen is of the vessel. So this would be a very big lumen, right? So that's a large radius. Smaller radius would have more peripheral resistance. Okay, the smaller the lumen, the more peripheral resistance you have. It's like that funnel example, right? Like if you try and pour a volume of water into a bottle with and without a funnel, which one's going to pour faster, right? The one without the funnel. So radius is one thing, length is another. So the longer the vessel, the more resistance you'll have eventually. And then blood viscosity, how thick that blood is, how sticky it is. And I gave this example when we talked about glucose and diabetics. People who are diabetic have a much higher viscosity. Their blood is thicker. It's like, think about like maple syrup running through your veins and water running through your veins, right? Which one's going to go slower? The maple syrup. So the higher the viscosity, the more peripheral resistance there has. The more resistance you have going through the vessels, the higher the pressure. The harder the heart has to work, maybe the faster and harder it has to pump to push that blood through those vessels. Okay. This is a good example here. So here is a normal, the middle one is a normal artery. So here's the lumen, that's where blood would flow. All right. And this one's lumen is very, very, very small. This one's lumen is very small as well. These have a lot of plaque buildup. So this whole thickness here is plaque buildup, probably from atherosclerosis, maybe like high cholesterol. Here's plaque here. This one even has a thrombus in it, which is a blood clot. So you can imagine that if you pour the same amount of blood in this artery, and this artery, which one is the blood going to flow faster and easier through? Obviously this one, right? The one with the greater diameter, right? Less peripheral resistance, nothing that's occluding this lumen. So what about blood volume? So as volume goes up, pressure goes up, and as volume goes down, pressure goes down. That's all directed by the kidneys. We're going to get into more of this when we get into the urinary system, but hormones are very important here. We have antidiuretic hormone, which we talked about week 2. Antidiuretic hormone, if you can recall, is a posterior pituitary hormone, and that retains water, or tells the kidneys to retain water and sodium. Remember, water follows sodium. So that's ADH, antidiuretic, anti-urination, right? So we're reabsorbing that water from the urine back into the bloodstream. And if we're reabsorbing water back into the bloodstream, our volume of blood goes up, and therefore our pressure can increase. So ADH is responsible for increasing pressure when pressure is too low. Same with this next example. This next example we're going to talk more about when we do the urinary system, but the renin-angiotensin-aldosterone system is also very important. We did talk about aldosterone. It's a hormone released by the adrenal cortex, and it's responsible for also retaining sodium. And if you retain sodium out of the urine, put it back into the bloodstream, that's a solute, so water is going to follow it. So we're also going to in turn reabsorb sodium, and that will also increase our blood volume and therefore increase our blood pressure. So these two examples are how we correct a low blood pressure. Now, how do we correct a high blood pressure? There's a couple hormones that we haven't talked about yet that are responsible for that. They're called ANP and BNP. Both of them are going to inhibit this system. So if we are inhibiting the reabsorption of sodium, we are excreting that sodium in the urine, right? And if we are excreting urine, we're also going to excrete water out of the bloodstream, put it into the urine. That's going to lower our blood volume and therefore lower our blood pressure. Okay, so that's how blood volume is regulated by the body in an attempt to help control blood pressure. A couple other pressure measurements I want you to be aware of is something called pulse pressure and MAP, or mean arterial pressure. Pulse pressure is basically, if you take your pulse, that is the pressure, if we were to measure that pressure of that expansion and recoil, that is what we would be measuring. All you do to measure pulse pressure is subtract the top number from the top number and the bottom number. So subtract the bottom number from the top number, rather, of blood pressure. So if your normal blood pressure is 120/80, systolic over diastolic, you just subtract those two numbers, and that's pulse pressure. That is a normal pulse pressure, is about 40 millimeters of mercury. Now, that's all fine and dandy, but blood pressure differs throughout the body depending on where you're at. For example, we take the blood pressure usually in the brachial region. If you were to take your blood pressure in your leg, for example, would that pressure be higher or lower than your arm, do you think? Okay, so if you're standing up, that pressure is probably going to be a little bit different than it would in your arm. I'm not going to tell you the answer because you're going to do a lab on this, but gravity definitely has an effect on blood pressure and how hard your heart has to work, depending on if you're lying flat in an even plane where all of your pressure is kind of equalized, Or if you're vertical, right, does the heart have to work harder or not as hard to get blood to your head and your toes as it would just next door to like your brachial artery? So I'm going to have you answer that question for yourself when you do this lab this week on orthostatic blood pressures. Mean arterial pressure, therefore, is a good average of how much pressure in your arteries that's delivering oxygen to your tissues. So pulse pressure, that can vary depending on where we're taking our blood pressure. Mean arterial pressure is a good average. So we take diastolic pressure, add that to 1/3 times the pulse pressure of wherever you're taking your blood pressure. And it could be anywhere from 70 to 100 millimeters of mercury. So that should also kind of clue you in on the answer to my question of where do you think, or as you stand or take your blood pressure in your leg, do you think that pressure is higher or lower? So with that, I'm going to leave you with this quick example because this class is all about homeostasis, right? So here's a good image of putting all of this together. So normal blood pressure, let's just say we're going to set our normal at 120/80, right? Let's say we go too high. So maybe like 140/90. Okay. Blood pressure rises. That's our stimulus. We have receptors that I've talked about now that are detecting that high blood pressure. They're detecting how much stretch those arteries are having to do to accommodate that high blood pressure, that high volume of blood pumping through each cardiac cycle. Those baroreceptors are going to detect that increased pressure, send a message to the medulla oblongata up here. What the medulla is going to do, which is something that we already talked about, is tell the SA node to fire less frequently. So that would be the parasympathetic nervous system secreting acetylcholine and telling the SA node and AAV node to fire less often. Okay. Peripheral resistance will also decrease, and to accommodate that increased blood pressure, sometimes what's going to happen in those arteries of the body, those systemic vessels, is that you're going to have vasodilation. And we talked about vasodilation last week, but that's just to accommodate that high pressure that's moving through those arteries so that those arteries don't have to stretch as far. We're just going to keep them dilated so that they don't have to go through that stretch and recoil. And then hopefully our blood pressure returns to normal. Opposite, if our blood pressure is too low, same kind of receptor and control center, but now maybe we're going to decrease our peripheral resistance. We're going to do that by vasoconstriction. So if we decrease our lumen area of where blood can flow, that's going to increase our pressure flowing through that. And then also we need to stimulate the SA node to fire more frequently to pump more blood into circulation faster. And so that would be that norepinephrine acting on the SA node to increase our heart rate and then hopefully increase it enough to go back to normal. So those are some good homeostasis examples. If you have any questions at all, please let me know. But that wraps up lecture for week 4.